we are having. And that is what we show. Okay. We had a slight issue that most of the numbers we had come down a little bit. But as time has gone on, we've started rising again, and the numbers are increasing. But this has another challenge, which we shall talk about later, that we are having to spend a lot more than what we thought we would need, and that really gives us a problem. When you look at the OPD attendances here, you see the dive in 2020, 2021, then 2021, 2022. Those are the areas of where COVID ends around 2021, 2022. Then now you see how the numbers are rising, and they don't seem to be coming down. But this comes with a challenge that every one of those patients, we have to look for the money to work on them, to help them. Can I look forward and see the rest? I'm going to go through these ones quickly. I think you see the trends now. These are the 5 patients. We have, this year you see how the numbers of referrals are increasing. And these are referrals from all over the region in Karamoja, but also beyond. We have patients from Tesola, from up to Lira. So these are patients from everywhere. Yeah, deliveries, you see the numbers. Last year we had a dip of about that, but now we have gone back up. The numbers are progressively increasing. Yeah. I just wanted to make a mention on this. This is very important for us. Maternal deaths. Last year we had 2 maternal deaths, and they all originated from the same place. That is Cotido General Hospital. And this year something similar still has happened. One of the major problems we've been having is that we've been having very late referrals. When we say very late, it's now like these ones, the mother has eclampsia, has high blood pressure, they are convulsing, and these 2 were brought in already unconscious, and they have had their obstruction for a prolonged period of time. Sometimes we talk to the people in Cotiga and ask what happened, and then they also tell us the mother came very late. And so it's not also their problem, but also the other things about the transportation of the patients, which impact on this kind of problem. So when these patients come to us, we try our best to save them. You go to theater, you manage their hypertension, you manage their convulsions, but they recover late. Most of these patients too, died after the operations within the next 48 hours without a recovery, full recovery. The other one from Iriri, this is a patient who was also had obstructed labor from Oliviru, came to Iriri as a referral from that side. Then in Iriri, spent some time getting transport to come. By the time they got to us to pick the patient, she was already doing badly. And by the time she got us, she has lost the patient and she was already showing signs of infection. We did the cesarean section, got the baby was already dead. And then the next day, the moment the patient woke up a little bit, she went out of the hospital. And 5 days later, she came back to us with a very severe sepsis. And she died 2 days after returning to the hospital. So these are some of the major challenges you find. When you get to the referrals or even patients who may not adhere to our needs or our regulations, we get some of these problems. But other than that, we try always to make sure we do not go beyond certain numbers. So this is what we had. So when you look at immunizations, we are having these very big numbers also going, and we are rising. There's a slight level there which has plateaued, which is a bit good. Like I told you, every time we see those numbers rising, we also think about the costs that are going to go into these patients. Now, one of the big reasons why these are many or these are happening to increase is because of the outreaches we are doing. We don't wait for the patients or we don't wait for the children. We always go out to meet them in the communities. They are talk about this a bit later in the presentation. Areas like the Poron area, Kaiderem, Konkukuria, somewhere deep inside there. Those are areas which have almost no health facilities near them. I think Poron health facility, has it been upgraded to Center 3 now? It has been a Center 2 for quite a long time. We are waiting for upgrading to happen, and it's isolated in a small area there. Or I would say a big area without any other facility. That would be it. So I find many times we go that side to be able to, and we get a lot of these immunizations. We can move forward, we see. When you look at HIV care, you see also our HCT is increasing progressively. These at least we know we don't have to worry so much because these are taken care of by the government. And our implementing partners give us a lot of help when it comes to this. Currently with UPMB and NECA and others, we are funding so we shouldn't worry as they go high, we can move forward. Talking about HCT services, the numbers of positivity cases, or positive cases, or what we sometimes call a positive period, they are really low. And I think that also comes back to what we have in NAPAC. According to last year's, we call it the Uganda, the HIV/AIDS survey. We had, let's say, UPHIA. We had 1% as the prevalence of HIV within NAPAC. Okay, that's a good thing in one way, and that also implies if people keep on doing the right things, you may not rise so much, and that's a good thing. When you look at the tuberculosis cases, we see that after 2021, we've had a dip, which is good because it also shows us that probably the cases of TB may be reducing. However, we are getting a rise in cases of what we call the drug-resistant TB, and that's a big problem. I may not have the numbers here. In Matan, we have an MDR clinic and a whole ward for TB. Okay. Currently, we have about 65 patients actively on treatment for MDR TB. That's about drug-resistant TB. And this is not a good thing. This usually comes from not treating the susceptible TB properly. I think we talked about it a bit yesterday. And it's a very big problem. Many of the cases, I would want to tell you that they're coming from the northern side. Kotido, Kabong, mainly. I think we have a few from Abim, but that's where most of these cases are coming from. And every time we follow them, we find out that we always speak more and more. We've been having a chance with help from PAM. The PAM team is giving us a lot of help. Currently, now with a few challenges, they are shifting us to IBI, back to Karamoja, and we are still enjoying a good service with them as we'll be able to reach to these patients. So I've already talked about this. We have 65 patients actively on treatment for MDR, and you see the cumulative number since 2015. Currently on the ward itself, because the way we are managing this is, we call it an ambulatory kind of management. We manage, stabilize, and then send the patient to there. We don't want
1 more minute to go.
No, let's go through a little bit. These are admissions, so I don't want to go through this a lot. We can move forward. Move forward again. Yeah, move forward. Now, these are the outcomes, basically, which implies we're not doing so badly. But I want us to move to the challenges and the other things we go for. These are just showing us the targets which we have had. We can move forward. Now, here is where I wanted us to look at. PNFPs are supposed to be give complementary services to government facilities and government work. And that's what we really do. In NAPAC, you realize Matani is the district hospital there. It's also where the sub-district sits. We are doing a lot of work with the district to make sure work goes on, and with a good relationship with them, we have a good cover there. And also with the specialists which we have and the doctors and everyone, we are increasing the expertise within the region, but also the district, which improves patient care. And in a way, by doing that, we are also like an implementing partner too, with the government, and also helping, working together with the other implementing partners. This is one of the things which PNF is basically are filling out. However, when you go forward, let's move forward. These are good things which we have. When we look at that, we have the continued support from the Ministry of Health. We are able to go forward because of the organizations which are working with us. One is supporting us. We have UPMB, we have UCMB, UHA, and then all these are giving us good relationships. So when you see Moroto Regional Referral, very close relationship, Soroti Regional Referral also helping us. And then the other thing is we have these high subsidized costs. We see every patient pays about not more than 15% of the total cost of the care. And that's why I tell you when the numbers rise, we start to worry because the resource envelope is not really enlarging that much. We can move forward. So these are the strengths still. I just wanted to look at one there, the low levels of intra-organization, operational bureaucracy. This helps us a lot also in that work goes on very quickly. Instead of having to go talk to the director, then call the LC5 chairperson, then call to get an ambulance to reach a place, we're able to get this done as quickly as possible. Then we have currently we also an internship site, and we're able to train interns over the last few years. I think since 2018. Currently we have 6 who are there. There would have been more, but we don't have enough space to house them. So we prefer to keep the number low, which also increases the quality that comes out of them. These are the major challenges. When you look at the bigger portion of them, the main financial issues. Okay? When you look, we are relying so much on donations. And, everyone will tell you currently donor support is reducing. Okay? When you look at how much is going on and how much the donors are putting on in, we are going down and down. That implies the strain comes back to us on how we can get the monies to look after these patients and also pay staff and do all the other things, buy medicines and all that. Very challenging situation which we are in at this time. And this comes back also to biotech. I told you it was a good thing, but now the highly subsidized, because if every patient is paying only 15%, for every 100 you're paying 15 shillings, then who pays the rest of the money? So we have some support from the government, PHC funds, but then the rest we have to get it from either the implementing partners which help us and the donors who help us. The cost of maintaining everything in the hospital is really also high. And then the recurrent costs, the wage bills, are very, very high. We have a problem. We are trying out to reach with our ambulance services as much as possible to wherever we can reach. However, when you look through, some roads are really very inaccessible. We had a tragedy about sometime last week where a mother couldn't cross the river, which has gone through, and the ambulance couldn't reach. And by the time the mother is reached, she has delivered one of the twins. She's dead due to excessive bleeding, mainly because we couldn't reach her. This is something we must call out for and ask that the responsible people, the districts, government, everyone is responsible. We need to make sure we can reach the families as much as we can. Because if we don't, then it divides and demarcates how far we can go. That is a very big process.
I hope we're there now.
This is the last slide. The other problem I already talked about it, and that is the late referrals. We always ask that to the DHOs, the district, people in hospitals. We try as much as possible to refer patients as soon as we can. Before at least you realize there's a problem, refer. Either Moroto, Machani, anywhere, and direct them properly. Mother left the limb, instead of coming directly to Matan, goes to really spend some time and then comes up to us. And all this time wasted in between, there is loss of life which is going on. And all that is a bit of a major problem. As if she had reached maybe 6-8 hours earlier, maybe she would have survived the excessive substitution. This is the last slide. I've gone through them a bit fast, but you can see our challenges and how I've not written how we are mitigating them, but with your help, we are managing and managing so much.
Yeah, thank you very much for that outfit. I think well at the time of the discussions, members, please, if there's anybody who has any idea that can make the hospital work better, we will discuss. For donations, please still it's free entry. At this moment, I invite Dr. Charles to come and make the presentation on the importance of One Health in Karamoja. Permit to recognize the Bishop of Moroto Diocese to this, and you are not late at all. Thank you for coming.
Thank you very much, Charles Pinyo and we, the Community Health Department. We have switched this session now to One Health. So the session will start with my presentation, then discussion for later. So we're talking about One Health in Karamoja, and our objective is to understand the critical importance of One Health in Karamoja, in the region. Next slide. So that is One Health, ladies and gentlemen. What you see here, that interaction of animal, human, and the environment. That is the watering point for humans and also animals. I know of a story in Loro. I don't know if it is still, the scenario still exists or it is past. That was sometime the cows of the LC would be able to drink first from the borehole before. So when they come, you have to step aside and pump for them. Then, so that is still One Health, and that's how the village resolved on handling water issues. So that is One Health. We are looking at animal, human, and the environment. So One Health. What is One Health? WHO defines One Health as an integrated, unified approach that aims to sustainably balance and optimize the health of people, animals, and the ecosystems. Ecosystems, we are looking at water, we are looking at everything, including air and everything, ecosystems. It recognizes and emphasizes the health of people, animals, environment, as closely linked, interconnected, and interdependent. One Health concept involves disciplines and sectors. As you can see in that picture, you have that first cycle, You have a lot there, you have environment, the plants, ecosystems, everything is mixed up there. These disciplines are care, veterinary, agriculture, water, environment. So this actual approach is particularly important for managing public health threats, for example, zoonotic diseases. And these zoonotic diseases are the ones that spread between people and animals. One Health for unified response, where we integrate expertise from various disciplines, recognizing the well-being of people. So what are zoonotic diseases? Zoonotic diseases are diseases, as I've said before, that are between animal and human. So you can get the disease from an animal, you can get the disease from a human. So that's what we call zoonotic diseases. And the examples are listed there. We have rabies coming from dog bites, Ebola, Marburg, like that as listed. You can see over there, including brucellosis, trypanosomiasis, and of recent mpox, which is also a zoonotic disease, the monkey pox, mpox. So what are the drive? Why we emphasize on this is because of the frequent interactions, and I would like to give you an example of what happened if we go back to the slide. We have anthrax. Those pictures were taken from Amudat, from the people suffering from the outbreak in Amudat. That is anthrax disease, and that came from cattle. That is the crossing now from cattle. Cattle are suffering from anthrax. Also, human beings are suffering from anthrax. And as you can see, those are veterinary people are trying to vaccinate and exercise, and that is all that is included in One Health. Now, why One Health in Karamoja? We have to appreciate that we take of the fact that Karamoja had the highest stock of cattle. That's 2.4 million followed by Ankole region. You can see from the picture. And then Uganda north. So we have the biggest stock in the country. We have the biggest number of the country. So it attracts a lot of attention. I remember we had gone on a workshop, and one of my colleagues was Rift Valley fever in Congo. So I was like, why? Says, but you have even more cattle than us. You have more wildlife than us. Falling sick, somehow it would leak out. But we were sitting on a time bomb, a much bigger time bomb, in regards to One Health. And that's why we have to these issues. Others that follow also unique and vulnerable climatic variabilities. We are lucky this year we have rains. This is where it's sure we have been having lean seasons, and this is the last. And the climatic variabilities, as you know, we end up with the food shortage, water shortage. It brings conflicts in our neighbors. in for us. They are more unfortunate than us in many cases. So all the complex challenges, we have our susceptibility to emerging and emerging diseases because we can do without the environment, but also enough the environment and worsening it for ourselves and the players in terms of environment and animal. So then the other thing is our complex landscape, mobile communities, that is actually, I remember we were doing yellow fever in accountability. I worked with Sister Molly, and all of a sudden they had told the village they had mapped in Morita had shifted. And we could not trace the village at that time. I think it had gone to another district. And these villages move with their people, of course, their VHTs also are not left behind. So you may find just pumpkins only. So it makes, nomadic health makes it very difficult with One Health. So imagine if we had a disease, anthrax, maybe those cows, and they have moved to where we don't know. And they are moved to another district. Just like yesterday I tried the issue of cattle raids. Uncoordinatedly, unlawful, illegal movement of, if we had to say it more politely, of livestock, and people going along. The destination we are not sure. Only sometimes, of course, ends in the corridor somewhere. So all that is going to complicate our issues of animal health. Because there's no way we are going to regulate cattle raids. We can't say that you raise systematically so that we should expect you to drop in there. So all those make a very difficult landscape for health. We have hard-to-reach, Sister Molly talked about the hard-to-reach areas, Karina talked about the mountains and what. So this is a very unique picture and this very special strategy tailored to handling One Health in our area. Also, it is further complicated by low literacy rates. Poverty, we usually actually takes the cup from us. So even they are saying actually actually region has more poverty than Karamoja. Literacy, we are very low at 25%. That still presents a very complex landscape so that you know that now this communication becomes difficult. You have to get deeper and lower to bring it out to the population to appreciate the community to appreciate what is all going on. So those are that is all about the landscape. We have had bad road infrastructure. So it's a complex of things. Why One Health approach in Karamoja? The unique context, as we cited before in the previous slide, it necessitates the One Health approach. We should have started yesterday, not today, not later. We needed this approach even much earlier. We would have had a better review today if we had this approach. We would probably not be having anthrax outbreak in the Pillar 2, in Amudat, if we had this done yesterday. So it helps One Health, it helps us to improve on communication, on collaboration and coordination. You identify what is at hand and work on it, communicate it, coordinate, and collaborate. And this collaboration is all about the sectors, as you can see, across the sectors for better health. Then we need to improve surveillance. detection and responses as a team for One Health. If that is done, then we shall get to appreciate the core benefits, the trade-offs, the opportunities for everyone to have an equitable and holistic solutions on the table. So what are the strategic interventions that we propose for One Health? We propose that we integrate surveillance and response systems. And I skipped out the word disease because it would narrow the scope. It is more than that. So surveillance, which should go deeper into the environmental issues. Forecasts, we need forecasts. We need the One Health still involves forecasting, weather forecasting. They should tell us that this is going to be rains, a lot of rains, and you should expect malaria, more cases of malaria, and then we plan for malaria. That is still One Health. There will be poor rains, there will be, so we know there are going to be prolonged droughts, and food is going to be an issue, it will be a linear. We plan for food to avoid malnutrition. So that's still One Health. So we propose to have a unified platform to integrate all this. And once again, I would like to assure you that it is data which will work, the EOC which will work. Emergency Operations Center, we need that. Then also propose to have formation of a regional One Health forum. Like I said, we should have had this one yesterday because already things are up. I've been with colleagues of Pheoc. They have raised the issues of brucellosis, which we keep seeing, and it is up and about. We have this issue of Cotido leading in that burden, Cotido, Moroto, Napak. And occasionally in Abilatuk also we see that, but most of those are the high cases of brucellosis, and we're still not doing anything. And to address it, we need One Health. People are trying to treat it from the clinics, but where is the cause? We are treating the effect. You have malaria, we are treating your fever, bringing it down, but we're not handling the parasite. The cause is in the animals. We are not doing something the other side. Brucellosis comes from consuming animal products. So we are busy treating only the effects, it is building up, there are cases that are increasing, and that's where we need again One Health to come in. So that we know if people, let's handle this side, you start from here, also clearing this side. But to make sure this thing is not continuing. Brucellosis is very well managed in the animal side. But we need to tell them, like you people, let's work together, we clear this. Anthrax is a base handled in the animal side, and we clear on the leakages this side on the human side. If vaccination is done on the animals, then what is left? Again,
you run short of time.
Yes. Then the other one is the capacity building and training. We need to come up with interventions for this. We made mention of this when we came to orientate the district task forces in Abilatuk and the Abudat. We need to train human and animal health workers. We need to involve the people of the environment and tell them that they are not alone and that we depend on them. And the community, and more especially the community, they need to know. Just like I pointed out again, our challenge is community, strengthening the community. So those are the strategic interventions that we propose. So way forward, would like your collective responsibility to emphasize so that we can emphasize the need for collaboration across all the sectors, like we said, animal, human, environment, so that we can achieve these One Health goals for better health. Two is commitment to One Health. Like call out the stakeholders, that is everyone, not just partners, all of us, to prioritize and invest, more especially the political side, to invest in One Health initiatives. And finally, I would like you to envision a resilient and health Karamoja if we embrace the One Health approach.
Thank you very much.
Yes, now, actually, this is now the next session for discussion and questions. What are the biggest challenges in implementing One Health in Karamoja? How can you collectively strengthen One Health approach in Karamoja? Is the district task force competent to implement One Health in Karamoja? And that brings up the AMDAT scenario again. Is the AMDAT district task force equipped to handle or not? Could it be the reason why the outbreak drags on? Those are issues for us to discuss, and how can we better integrate the various systems across these sectors, where we have people collecting data about the animals. We have 10 rabid dogs in Kotido. We know that before they bite someone. That is data. That someone reports, we are reporting 2 dog bites in the Kotido. Animals reporting 20 rabid dogs. We now, you get it. So that's what we want. So how do we integrate? And how can the regional One Health program play? What role can it play in the region? Thank you very much for listening, Chair. I'm finished.
Thank you so much. The question was, what do we do? How many districts we have in Karamoja? And if every district has got a health educator, do they go to the shy? Those are the questions. So when you get back to the district, if your health educator is really or shy, then we will not achieve. Thank you very much.
Thank you, Dr. Charles. Ladies and gentlemen, we're supposed to have a bit of like a panel discussion, but however, we may have just expert opinions from the different key stakeholders within the House. With us, we have key stakeholders that have implemented One Health before, and we've seen that case in Amudat and some other places. So I will just keep selected discussants. You may actually talk from your various points in answer to these key questions. So what are the key biggest challenges in implementing One Health in Karamoja? So we would love to see the key experiences. Within the House, we have the DHO Amudat. We want to have a shared experience, a perspective from your end. We also have Dr. David Wanguzi from the National One Health Platform. He chairs that the One Health, so we will have an expert opinion from him, such that the stakeholders in the House are able to appreciate One Health in the context of these questions that we have here with us. Also from the partner end, from UHA, we have Dr. Andrew Ochero. He's in charge of One Health for UHA. And so we will listen from them individually in the context of some of these questions that we may learn some of the experiences, and then we'll have the RDC. Do you have RDC? Yes, the LC5. Yes, the LC5 Amadat. You'll also share with us what are key stakeholders, because we want all of us to appreciate. And this is where health is going, that in the next 10 years, majority of our health problems are going to be around here, most of them, just like some of them are picking up already, the zoonotics. Why is it that we're not eliminating anthrax? From its process to human beings, it goes back to animals, back to human beings. So how do we break such cycles? And some of those are questions we want to ask ourselves. So on this, permit me, Ruth, come and pass this microphone. I'm not going to invite them to sit here. I know the hotel had arranged for us something of sort, but we will want to listen from them at the comfort of their city. Please get this mic and have it passed on to these experts. So we will start from Dr. David Mwanguzi. You give us a national perspective, at the same time a part of the lessons learned from across the country and key recommendations. In the context of some of these questions, what is working, what is not working, and what can we do better as a region? Dear stakeholders, let us keep listening to some of these expert wisdoms and opinions. So, Sir, you're welcome. You may take the comfort, either stand in front so that they see you, or you can stand where. So I want to give you the leverage and the freedom to do what you're comfortable with, sir. Others, you're most welcome.
Thank you very much, colleagues. My name is Dr. David, an institutional representative to the National One Health Platform. And I may say I've been a little bit lucky because I've been coordinating most of the responses to zoonotic disease outbreaks in the country. I might have interfaced with. And at the national level, we embraced the One Health framework in 2016 that eventually gave rise to what we are calling the platform at the national level. And the sectors that were championing that cause were four. That was health, agriculture, trade and industry represented by wildlife, and then Ministry of Water and Environment. And challenges that we're facing at that time were mainly zoonotic diseases. Those were some of the priorities that were identified. Then there was the issue of environment, the issue of biosafety, biosecurity, and of course there are other emerging issues that are coming in, like food safety, that actually necessitate approach. The reason is that we have been faced by quite a number of these challenges, and initially we were trying to hold them per sector, but we could not actually get a solution. Dr. Charles has already mentioned most of the challenges, but of course the first challenge we had at the national level was getting people to get rid of the feeling of this is my mandate, and it's something that we have actually been struggling with, mandate. How do we do things? Are we doing them the right way, or we are doing them right? And that has struggled on for long and long. But what we did was that first and foremost to ensure that most of the structures actually embrace the One Health approach. For instance, the National Task Force is multi-sectoral, multidisciplinary, and it is chaired by the Director General, but there is a provision that if we are handling something that is of zoonotic nature, then the Director of Animal Resources can do that. And Dr. Charles talked about quite a number of challenges. One of them is the training that at the national level we have actually envisaged. It may not be specific that is for just zoonotic diseases, but the entire response of public health hazards, that we also have a fellowship program that is ensuring. It didn't actually remind you that, you know, these definitions of One Health have gone on changing over time, but they still 98% remain the same. So the latest, when we had the quadripartite, because initially we were talking at the global scale, we were talking about the tripartite, because there were three international organizations, the World Organization of Animal Health, WHO, and FAO, but in 2022 were joined by UNEP to form the quadripartite, and of the principles that was talking about of One Health, we added the capacity building, and I'm glad that I was talking about it, capacity building, asking whether the districts have the capacity. So, in the Ministry of Health, we have the fellowship program, but in the Ministry of Agriculture, I'm glad to mention that they have what they are calling the e-service, in-service applied veterinary training. All of it aimed at ensuring that we get the necessary capacity and the competencies to ensure that we can actually contain most of these challenges that are facing us. I believe the challenges are almost cut across, but one of the biggest challenges we have been facing is because that we don't have the resources to implement One Health activities. And we are saying that One Health, the approach might be new, but the activities have been there. So what are we saying? Can we first and foremost, before we look at the partners, can we try to mainstream? Because we have been controlling, we have been trying to control anthrax, we have been trying to control rift valley fever, but other sectors. Now we are saying that we should look at the areas of intersection. What do you bring to the table? Let us look at the big picture, working in walls and their relationships, other than looking at the constraint parts. We are looking at controlling anthrax. What is the objective of the whole Karamoja region? Not the interest of the federal department, not the interest of the medical department. So what is the whole? But if we are looking at the whole, then we are going to ask quite a number of questions. Who constitutes the whole in this process of fighting anthrax? And what does the whole, what does the constraint part do on its own? Uniquely, that is different from what we do. And how do we relate? And therefore, if we are to achieve the objective of fighting anthrax in Karamoja as a whole, not as vet, not as medical, not as social, how do we rearrange the relationships that we have been having as we interact to ensure that we achieve the objectives of the whole? These are the questions we are going to ask. Identify the key actors in the process. I was very happy when I was looking at one of the presentations where they were saying that we have 30 implementing partners. Well, we must be very lucky. Don't you think so? 30 IPs. But before we bring them into the picture, before we say we sit with them and control anthrax, do we know how they operate independently? Or do we have an inventory of all these partners and the actors that are working in the district? Do we have them? The inventories? Potato, do you know how many are working? Amdat, do you know how many you have? Do you have a list of them? Yes. Do you know how they work independently? Do you know how they interact with you and the other people, the other actors? What do they do? Is there a possibility of sitting together and we rearrange the way they work to ensure that we achieve what we want? Because to me that is an opportunity that other districts don't have. That IPs. Is the district task force competent? I think those are some of the questions that the local population may answer. But in most of the areas, we are building competence. No one can ever say that I'm 100% competent to do what I'm supposed to do. That's why training is regarded as one of the key principles of One Health. Build the capacity. The district task force. We are training. We are doing event-based surveillance. We have just finished the rolling out of the integrated disease surveillance and response trainings. And a number of other trainings are coming. We are doing the training of One Health. In 2019, we began decentralizing One Health. We have covered a few districts. Our major focus now is to ensure that we have regional platforms that can cascade capacity building as far as One Health is concerned. And I'm very happy when Dr. mentioned it as one of the recommendations. Because the national level is big, we cannot be everywhere. Okay? So integrating surveillance systems, this is something that we've been struggling with at the national level. But we are saying that even where we have not been able to integrate, can we communicate? Did we see that one as one of the principles of One Health, communication? Why should we have 30 rabid dog bites reported in Ministry of Health and the Ministry of Agriculture is saying for us we have 5? can't the health department and the vet department sit as reconciled? Actually, what he was saying, we did a survey in one of the districts and we found that the surveillance data was not much. Then we were saying, why don't you first sit before you communicate to the national level? And that is the low-hanging fruit that you may not say that you don't have money, isn't it? Because sharing. I was in one of the districts in southwestern Uganda. We were trying to respond to an outbreak of Rift Valley fever. So our first visit was to the office of the DVO. So he opens his laptop. We look at what he has. He had initially sampled some animals and sent samples to the lab in Entebbe. And he had some animals that were showing that they were saturating. RFF was saturating the animals. But we had just had a fatal case of Rift Valley fever in the municipality. So we're asking him, did you share this with the health department? He said, you see, when I share, they will say that I've declared an outbreak. No. So can we share? Because some of the information that we get is going to assist us to build robust early warning and response systems. What role will the regional One Health platforms play? I think that one I've already talked about. You are going to cascade the trainings. You are going to do the mentorships. Okay? You are going to facilitate response, preparedness and response in areas that we think that we are sharing those threats. So, if I was talk about One Health, I can talk until the cows come home. However, I don't know whether I've answered the pertinent questions that you wanted me to answer. Just in case I've not answered them, I'm still available. Thank you very much.
Thank you, Dr. David. You've given us more time because it gives it from a national perspective and also from an experienced point of view. I know there is an aspect of the partner we are getting worried also about the partner commitment. I think I need to give Dr. Andrew Ochero a component to share with us briefly on the partner perspective on One Health Fund.
Thank you, Chair, for the opportunity. The big drama, One Health has spoken, but I will basically be talking, as you said, from the partner perspective, to basically re-emphasize what has been mentioned by Dr. Mwabuzi. And I will, of course, be using examples from the work that we have been doing at USAID UHA. Our mandate during this first program year, second program year, I beg your pardon, has been to strengthen health emergency management. And basically that has been to functionalize the emergency operations centers within the 7 regions that USAID UHA covers. Fortunately, Valley was already functional and has remained a benchmark. It was started some time back during the COVID period. And Moroto, again, thanks to the Rights E program, had reached some level where they were almost ready for launch. Unfortunately, that program ended, and USAID tasked us to make sure that the Moroto ELC came into being. And of course, there are others across the country that are still working towards being launched. Now, the One Health approach has been central to what we want the emergency operations centers to do as they strengthen response, disease outbreak response across the region. Right from the the setup, their governance setup. We have insisted that the steering committee is made up of persons from the different areas, from animal health, from human health, and from the environment. We also know that the EOC is supposed to play a significant part in coordinating these different partners who should support with resources, with skills, with technical skills, and all the other aspects that make up the different pillars that the EOC is supposed to undertake. And therefore, it is one big challenge at present, as Dr. Mwangozi has said, but it's also a big opportunity that we have. We have recognized that there are a number of partners who can easily come together and respond to the different disease outbreaks. We have recognized that there are a number of partners who can help us to fully functionalize the EOC. UHA has done, yes, a lot of work in providing some of the furniture, the equipment, capacity building, of course, working hand in hand with the Ministry of Health. But there are still certainly a number of issues. As you visited yesterday, they had a desk for the call and dispatch center, and we are still looking for partners who can, for example, support in ensuring that we are more efficient in capturing information that makes up the event-based surveillance. Or we are keen on ensuring that indicator-based surveillance data is more efficiently captured and brought in for analysis. And all this really depends on proper coordination, proper integration of our different. When there was that district task force meeting in Abu Dhabi, and there was this big argument around health was puzzled that their samples were not proving the existence of anthrax in the district. While on the other side, under human health, there were a number of samples proven positive. And it was a big place of contention, which if we were talking, if we were already had a platform of understanding, I think some of these things would have been earlier resolved. I also recall the situation in Kwen, where Bokot pastoralists crossed through the Pheoc nature reserve. And of course, in that process, and they do that seasonally, in that process pick up spores, and of course anthrax. They get into Kwen when the cattle are diseased. Of course, economic activity will warrant that sick or dying cows are sold off to people that are unknowing about what is happening in these cows. And of course, many of these cows are then driven back, again, causing more problems within the Karamoja region. These are things that talk to the need for coordination, and it has been already greatly emphasized. So coordination is one, and I've also talked about resource mobilization. That is also a challenge, but an opportunity, which I do also encourage that we all come together and as a team to ensure that this is achieved. And indeed, the Regional Emergency Operations Center shall be a key beneficiary and will be able to respond to disease alerts and to these outbreaks whenever they occur. How do we collectively strengthen the One Health approaches in Karamoja? A lot has been said about bringing the different people, health, human health, animal health, human health, and environmental health. And of course, we have mentioned the Regional One Health platform. But I might also opinion that at district level, we need, and Dr. David, you have been key in helping us to activate One Health district teams. I think these are the people that form the root of the One Health approach. We need to have them, of course, at community level and building up to the districts. We need to have these teams functional where the DVO, the DHO, the district surveillance focal persons, the production persons are able to talk together, and we would wish that this was on a regular basis, even out of crisis, so that whenever it occurs, it finds a team that is ready to flip over and become the district task force. So my encouragement as a useful action would be that each of the districts have a team that are already talking, and they're already talking One Health, and they're already able to use the data that is provided from the different sectors to do surveillance and to respond to alerts when they occur. And indeed, the capacity building is necessary. UHA has already been working with the Ministry of Health. We have the ECHO platform. It's a virtual learning platform that we are using to make sure that the different resources or focal persons within the different districts are invited to learn a lot more about these different disease outbreaks. We did one for rabies in Busia, where we presented a case and then had an expert panel to discuss about how to manage the different aspects of rabies. We have done the same for Mpox now, and I think it's going to become more active. They have just reported another confirmed case in Mayuge, just very close to us in the Soga region. And we need to become more active in using the forum to build our capacities, to know how we are going to handle the suspected cases and those that are confirmed. And indeed, back to the EOC, they need to know what to do in case of such outbreaks. So capacity building for the task force is important. And indeed, we are saying that we want the different sectors to be part and parcel of that of the task force. Integrating the surveillance systems, I've kind of alluded to it. UHA will be supporting the Emergency Operations Center to do data quality assessments and to make sure that the different sources of data from animal health, like the Empress database, the one from human health, the EIDSR, and others that the other different sectors are using, kind of show us the same information that can be corroborated across the different databases. Of course, making them become one is still probably a long way off, but we can still work to see that they speak, that they provide the same information, reliable information. So, like I said, the role of the Regional One Health Forum is key, but let us start from the grassroots to make sure that One Health is portrayed within the districts as well. And in the very, the most outbreak-prone diseases, we have agreed with the team that we shall be participating as UHA in activating those One Health teams. And we hope that it shall follow across into the other districts. Thank you.
Thank you so much, Dr. Andrew. Members have listened to the panel perspective. We just in a few minutes time, just give like 1 or 2 minutes to really spot on discussion. The DHO Abuda to give us his experience of how he has handled. And the other question we'll ask ourselves is the whole Karamoja has cows and it's nomadic, but why Abuda? Some of those are questions you need to ask yourself. And why the southern belt? Many of the things are happening. And just tell us what is working, what is not working, just in a minute or so.
Thank you very much. I know I have very little time, but I've been selected to give the experience of One Health as a result of outbreak of anthrax in that. I need to give an overview very briefly. We had a rumor of outbreak of anthrax on 13th March 2024. And on 14th, we had a DHT meeting to discuss about this issue. We came up with the district rapid response team, and on 15th, they went to the field. So they went and viewed data at the health facility where this case was reported, and they also went to engage the community where this problem was. The team composed of lab, medical doctor, vets, health educator, and of course our driver. So they gave us a report and they took off samples. After some time, of course, we got results for the samples. 15 samples of humans were taken and 6 for animal and 2 for environment. 6 out of the 15 samples from human were positive. 6 out of 6 for vets were negative. Yet, as far as we are concerned, there is no way a human being can contract anthrax apart from animals. There is no human to human, the chances of human to human transmission is very minimal. So we are left in the dilemma, as Daktari has said. Okay, we went ahead and conducted the ETF, and we shared the results. We left all of us puzzled. They took off samples again, animal samples. They were negative. And for us, as a health, since we had confirmed that was by PCR, we went ahead the transmission. We an outbreak preparedness and response plan with support from partners, Ministry of Health, and our regional hospital. WHO was technically there, but unfortunately, there was minimal funding for this response plan. So we had to use the minimal available resources in the district to conduct radio talk shows, train the health workers from the most at-risk sub-counties on diagnosis and management of these cases. So that is where we are. Now, we are still having the problem as we had yesterday. It's ongoing because of little resources and probably we get this opportunity. Request partners who are around here to support us resolve this problem once for all. Your questions were, why Amadas in particular? I think we are the people with the most mobile population probably in this place, and we move in several districts. One of them is where anthrax has been reported sometime back. And you know anthrax is a spore, so it can survive for a very long time. So it's like our animals went there and they came back, got the disease. By the way, we also got 300 cows, but we don't know what killed them because the vets said they don't have the disease. And for us, we are saying, when we take off samples, they are positive for anthrax. The vets have tried this and they have negative results. So we don't know where we are getting this thing from. Ideally, that is it. So members, I'm not going to respond. Colleagues have already given expert answers about it. So, thank you so much.
Thank you so much for that shared experience. So members, you see the public health gap and you see part of that experience and the need for us to learn to work together. I never know the event may tell us either sample taking or the environment. You know, those are questions that need to be answered and the need for us to work together. Do I have a political person, the LC5? Yes, just give us in a minute how you managed that situation in Abu Dhabi, so that the LC5s and the RDCs are able to appreciate your response. You can give them.
Yeah, thank you so much. I don't think I really have to say much because the DHO has spoken about the issue. But as we convene here and still have that kind of gaps, it makes me on the farm. Sometimes what people used to say, that the only difference between an animal doctor and the human doctor is that the animal doctor eats its own client. So yeah, because there was a lot of variance. How could the human doctor say it is positive when the animal doctors were still giving 6 out of 6 samples as negative? But equally, is a very long stretch of porous border. So many animals come accessing pasture and water from. And of course, like Dr. Abdul said, we have the presence of the game reserve in Abu Dhabi. Even up to now, we're still battling to see that those animals, after it has rained, are out of the park. But it's unfortunate that as a country, there are a number of policies that are developed. I was able in 2022 to attend a validation meeting on draft integrated regional coordination mechanism, guidelines for prevention and control of zoonosis, where the East African Cooperation had pledged to ensure that they are working together with the GAD in ensuring that such kind of diseases are easily controlled. But that does not lead to happen. Even the GAD protocol has not been implemented up to date. It is there every time they keep reviewing it, but it has become hard to control on the movements, especially of livestock and even people across borders. So as we try to work towards One Health, I know it is key also to involve the East African Cooperation, the ministry, so that those neighboring countries, they have to strive to control as much as we do, especially in Uganda. We saw what happened with COVID. As Uganda were coming up with SOPs, Kenya was relaxing. So as a district, it was very important that we had to use the radio, and that radio was a Kenyan radio, because we don't have a radio in Amudat. So we would cross to West Pokot, talk to them about limitations on the movement. That animals today are migrating from west to east, from east to west. So what is very important now is that we are having a center, an emergency center here. Probably the data that we will be receiving will be used accordingly to address some of these challenges. But otherwise, this is something that still calls for all the ministries, all the partners to come in. Thank you so much. But importantly, it is very good to involve the traditional leaders. I remember when our team one time went to radio, but the callers were responding saying that, how do I just throw my animal after it has died? They are told they need to bury or even burn, but they are saying that is big braggart. We cannot just throw our animals like that. So.
Thank you. Now, the other lesson we are learning is that we need to have the cultural leaders in our task forces. It's part of the key lessons and the actions we need to take on, because they're the ones that will drive this information very well across the different health challenges that we are having. I think so much. I think that discussion on One Health is a stimulus to what we will be going back to, yes, to discuss more at our different district levels. Dr. Pandey, you have a comment?
Thank you very much. I'm a bit intrigued. First of all, thank you very much for the discussion regarding One Health, and also the discussion regarding anthrax. But I'm intrigued by the fact that data from human health was not, or data from the animal health was not really in line with what we got from animal, from human health. That gives us a challenge in our surveillance system, because we must be able to know, to detect where these problems are arising from. And once we fail to do that, then most likely the problem will continue to carry, because we can't address where the source is coming from. So there is what we call epilinkage, epidemiological linkage in surveillance, which helps you to link the cases with the ones which were okay, the source. Laboratory linkage, epidemiological linkage. I think we should engage into that. And even you can go ahead and look at the genetic sequencing. So I would like just to ask our partners here, to request our partners to see if we can, because if we can engage in that line of thinking, maybe working with the people, our laboratory people, CPHL, and other people we agree on that, to see that we what will be because there is a that we address it. That's just the IPs, the partners. How can we help? How can we identify this? And also the people from the National Public Health Emergency. This should not be left in what? I think we still have resources. We still have something that we can do to really identify where that problems are rising from, especially in Abuja. Why is it Abuja? What is it that we are not doing right, so that we can deal with something that is to contain that epidemic? Thank you very much. That's what I wanted to share. But that's one of thoughts which we can extend. We don't resolve it today. We may have to think about it later in other further discussions and see how best we can address the problem in Abuja. Thank you very much.
Thank you very much. In interest of time, I have to get special permission from the chair. Just to mention this, that there are certain tools which can be used to exhaust on some issues. The AMDA story I mentioned yesterday, I'm just repeating that we propose to use one of the tools called the intra-action review. There are three key tools from that the show has given us. The action review, we did one for measles in Moroto. Early action review, we review the early response, we review immediately how it is taking off. We establish any challenges and that helps in managing, responding to the outbreak. Then there is the intra-action review and after-action review. Now, That outbreak is dragging on for a very long time. It definitely calls for deeper action. It will give us it will give us answers to what is going on in AMDAT, including investigations, including stakeholder, what are contributions, funding issues, everything, right from planning all the way up to implementation. We have proposed it, we have discussed with the World Health team of UHA, and we have been given a go-ahead to write up a concept that we can go, and we shall sit in after like 3 to 4 days, and to span across all the stakeholders, health workers, local authorities, until we get to interact with the national people to establish why the AMDAT outbreak is still dragging on up to now. From there, and what happens with the reviews is we shall come up with the recommendations. So that's what I want to tell the House. Thank you very much.
Yeah, thank you very much. Let's give the applause. Thank you so much, family. I want to make a few remarks before I go. I want to thank you and the organizers for this privilege for having allowed me to chair this session. Most of the times we do planning for people, the people who may not even be related to us, but because we are being called to serve. Unfortunately, we do not look at our own lives. We have labs in every district. We never go for medical checkups, ourselves as individuals. You cannot have, we fear that if we lost one of you, then we're going to have a big problem. You know, human resource, we are crying for it everywhere, but we do not treasure our own lives. I want to appeal to everybody who's here that once you get opportunity, get time, get a medical checkup, know how you are doing. And lastly, blood is not sold in the supermarket. It has got to be donated. And not everybody is ready to donate blood. Next time we have such meetings, I propose that the blood bank come around each time and have 2, 3, 4, 6, 7 people donating blood. I thank you all.
Thank you so much, RDC. Clap your hands for our RDC Cotillo. Yes, before we should we all have some you here with us as lunch comes through a bit late in 30 minutes time. We have a few key partner presentations to the stakeholders, and then the others will also spread it partly after lunch, and then actions, and then we'll be closing. In just in a minute or so, I would love to have the Bishop has requested to say a comment to the stakeholder. The Bishop of Moroto Diocese, he is a big stakeholder in driving a lot of health agenda you're concerned.
Thank you very much, Chair. So, first of all, I want just to add a word of this discussion, very interesting discussion. Why don't we use also our communities, our pastors, our priests, our sisters, directors of the communities, spread the awareness program about this and it's free of charge. It's a matter to address the leaders in a very schematic way. They can spread the news and make people aware because they have in contact with the grassroots of the situation. This problem. One thing I would like just to, I saw so many partners here. I'd like to express my gratitude to all of them for supporting us and making possible, viable, really a service, the health sector in our region. Well, probably before you heard the presentation of Matani Hospital. like just to spear favor of these non-for-profit entities that we have in our region here. And I want just to convey to you and make you aware that we have been working for so many years, and the granting of service, at least our humble service, has been granted for all these years. But we are really now going through a very hard times. Our resources are dwindling. Our possibility to get more resources from outside for donations are becoming more and more difficult. I tell you, I spend sleepless nights to think how to solve this problem. Just to tell you concretely, Matang Hospital is on the brink of collapsing because, you know, at the end of the month you have to pay the people don't want to pay. It's good, you have to eat, you have to maintain their family, they have children, you have to send them to school. And it is a really pity that we are failed in so many ways, in so many situations, and up to now, we have just met with that fear. So I'm just appealing to those who can really now hear my cry, my appeal, my request that anything, something can be done in order not to let these realities die completely. You know, we have got two lines. In Karamoja, the two lines are the government realities of health system and the for-profit health system network. And these lines have been working, both of them together in a wonderful way up to now. Now one line is almost shrunk. Those who are expert in this system, they can give us the right treatment. But of course, the right treatment is just to inject a bit of support, a bit of help. So thank you very much for listening to me for this beautiful meeting, and I wish you success and more and more, you know, God blessing you in the mighty of works. Thank you very much.
Thank you, the Bishop, Karamoja Diocese. What we informed yesterday, we're celebrating Matang Hospital has been, we evaluated all the CMOC sites from the Center for Level, and St. Kizito Matang Hospital still emerged the best performing according to the Tally Center. Quite a number of quality indicators were assessed, and they received the award yesterday, and we congratulated. And thank you so much. So amidst the middling resources, you're still doing fine, you're still doing well, and we still recognize the excellent performance from St. Kizito Matang. Thank you so much. We know God will intervene always. Find a way, and stakeholders are here to see how to support such a facility to continue thriving to deliver quality services in Karamoja. Ladies and gentlemen, I want to trust us. All these successes you see happening here is because of the investment of the health development partners in the region. We've got in the house the UN family, we've got the USAID funded family. I also want to update us that last year we had cities in the south, in the north, but now we are a one block supported under now one agency and the USAID. But we're also glad we have the UN family supporting the region. At the same time, we have the Irish aid around the Italian aid through PAM and the other different stakeholders. And so we just want to give them a few minutes, ladies and gentlemen, so you can have a simple look into the few key asks that the partners are asking from us to. They want us to really participate with them because they are part of us in achieving these indicators. And that's why I want to start with the block of health development partners. I think I want to start with the USAID block where the team integrated presentations, and Dr. Joseph, the regional project program director UHN, will give us that presentation from part of the USAID family in this meeting. Just pay attention and look forward to lunch break as we with the time. Thank you.
Thank you. Good afternoon, colleagues.
Good afternoon.
I know it is before lunch, but the body is already showing lunch effects. I'm going to request that we stand up a bit. Let's stand up and stretch a bit. And presentation. Okay. Yeah, we can raise our hands a bit. Yesterday, I saw the chairperson stretch. Okay. I also want to see that their toes. Okay. Okay, good. We can take our seats. Thank you very much. I am going to quickly walk us through an overview of what a number of USA partners are supporting within the region, but I will also go beyond that and include one or two other partners that are not USA funded. So we have a UHA, and UHA's purpose is two-pronged, looking at survival and well-being of vulnerable populations, as well as strengthening our health system. That is UHA's purpose. And next, we have those three key result areas. We are looking at improving access to and utilization of quality services, as well as local ownership and leadership for sustainable health outcomes and strengthening our health systems. That is what UHA is doing next. This is where we are. UHA is not only in Karamoja, we are in 7 regions, and in Karamoja, we are now covering all the 9 districts of Karamoja. We have 3 districts where we have a direct family health service delivery. That is Kabong, Moroto, and Kotido, and then the rest, we call them health system strengthening districts. Next, this is a quick summary of actually the number of facilities we have. In total, we have about 150 health facilities, and that's the distribution. You see already yesterday's discussions already facts that if you look at general hospitals, we have 4 districts, 3 districts. 4 districts not have, and then health center falls again. But key to note, Moroto, though it has a regional referral hospital, does not have a health center or a general hospital. And the others are spread out. What we see, we have very many health centers, and yet they are the lowest, they are the least supported, least staffed, and they are widely spread out, and many times this is where our services are actually being provided to a number of our people. We want to appreciate the NGO platform, the NGO, the private not-for-profit. We have about 21, and yesterday Matani showed that actually they are also doing a lot of great work. Next. So this is a quick summary of what UHA supports. We really support, if you look at the first key result area, we focus on quality improvement, we focus on family health service delivery, and this is what we do. And then when you look at key result area 2, our political stewardship, our area is mutual accountability. We are looking at multi-sectoral coordination platforms. We are looking at strengthening capacity, not only for the CSOs. The third is health system strengthening, looking at financial, public finance management, data use. We are strengthening HRH and looking at supply chain. That's what we do across the district we are supporting. Next. So the other partner we are going to speak to is the G2G, government to government. And next. So government to government scope is really to strengthen capacity for the regional referral to implement comprehensive HIV/TB services, as well as the RAMCA, which is also United Maternal Reproductive Health programs. Next. And again, this is a quick summary of where some of the facilities they actually provide. Now, the regional FARO's hub and spoke model mandates them to do capacity building up to level 4. And then the expectation is that level 4s should be able, the hospitals and level 4 should be able to cascade that impact downwards. Next. The other pattern is malaria reduction activity. Unfortunately, they will be exiting at the end of September. They will no longer be with us. But what are some of their aims as they are with us? Improving survival and well-being of Uganda's most vulnerable pregnant women and children in selected regions. They are covering a geography of about 53 districts, including Karamoja, and then the target population was 12 million. Their focus areas are strengthening community and household capacity to own malaria prevention and access high quality malaria services, work with the targeted private for-profit health facilities to strengthen and also improve technical, managerial and financial leadership capacity as well as accountability. Next. So they have all these details and some of the successes in QI projects being implemented, community engagement as well as schools. The next. So this is where they have also done a number of things. Continue. The next. Continue. So leadership engagement, accountability, they have created the MAM task force meetings in the 9 districts, collaborating with the regional referral and UHA, they have conducted support supervision on a quarterly basis. And that's what PMI, malaria reduction activity, have been doing. Next. Next. So the next other partner is Karamoja, which is USA local partner Karamoja, being implemented by ANECA. ANECA as well is covering all the 9 districts. The activity was made possible because of the USA funding. Next. And who are they? LPHSK is a 5-year grant which is going to be implemented, which has been implemented since 2017, and that was IntraHealth. But for LPHSK, they will be implementing up to the 21st of October 2026. And all those are the districts they are working within. Next. What are the key result areas? Quality facility-based HIV and TB services being provided, quality targeted high-yield facility HIV testing and counseling services provided, all those diagnosed with HIV TB are being initiated on treatment, all diagnosed as well as building institutional capacity for the target districts. That is LPHSK. The other partner that is supporting our Karamoja is the local service for HIV and AIDS activity, LSDA, being implemented by UPMB. And the goal is really to support achievement of government goals, reaching and maintaining HIV epidemic control. And their key objectives, again, just like LPHSK, they are looking at new HIV infection prevention, 95% living with HIV knowing their status, 95% put on treatment, 95% of those on treatment achieving biosuppression, and again, the selected PNFPs is having capacity to maintain epidemic control and maintenance. That is spread in a big facilities, Kotido 2, Kapong 1, Nabila 2 1, Karenga 1, and others as detailed there. Next. So these are some of the other focus and key asks, but I'm going to give a summary at the end. Next. The other partner is USAID Pact Karamoja, which is program for accelerated control of TB within Karamoja. Their major focus is TB, and their coverage has been all the 9 districts. They are also funded by USAID, and Unfortunately, the gates is another that is in their final year of implementation. The project is closing January 2025. The goal is to scale up evidence-based and high-impact interventions towards achievement of vaccines. Next. These are some of the priority interventions we have undertaken. Differentiated TB service delivery models, where we have the committed TB points. We have targeted intervention for hotspots, facility-based interventions. They have also had strategies to strengthen TB service delivery, looking at coordination, looking at the DAP implementation, as well as using data, digitalization of their interventions, as well as research and innovation. They did a mobile TB study and even disseminated next. These were some of the key results that Pact Karamoja was aiming to achieve. The other partner is QAM. QAM is not USA funded, but like I said, wanted to also speak to what they are offering. Their vision is a world where health is accessible and guaranteed to all human beings. And the main area of intervention is really health system, strengthening maternal and child health, nutrition, HIV, TB, malaria, some of the areas they focus on next. This is their approach, which is community-based care and community facility linkages, involvement of the district leadership, medicines and supplies availability, health information, enhancing human resources, as well as facility-based services. Next, they have a number of projects they are implementing. All in one, which is the integrated actions in health, which is majorly in Moroto and Napar district. That is running up to April 2026. Then it's being funded by the Italian government. The other is strengthening digital systems by the Embassy of Ireland, and it's running up to September 2025. We have the ELMA funded project looking at capacity of health workers for maternal, neonatal, and child health, and this is running up to March 2025, and it is in those 9 districts. Next, they have another from Fire Foundation, increasing coverage of TB prevention, and it's running those 5 districts. It is expected to end in September. The other is the malaria activity under Global Fund, and this is ending December 2024 in all the 9 districts. Then we have the Karamoja Regional Keso DC7, again Global Fund, which is also ending December. Finally, we have they have been working as sub-partners with one focus coming with USAID Pact Karamoja, focusing on TB interventions. Next. So what are some of our key asks? And I've been a bit brief, really touching the top. But these are our key asks. One is we appeal for continued health partner coordination, not only at regional level, but also at a district level, and if possible, even cascade this down to sub-county facility level. This is very critical. We are all targeting the same population. And really, as we do this, we are asking that as you do the coordination, think about ensuring that there is no duplication of resources. It's very, very important, because if we permit duplication, then that is wasted. But also advocate for integration. That is our very big ask to all the stakeholders in here. The second ask is get interested in what we are doing, ensure we are jointly planning, ensure we are jointly implementing. As partners, sometimes we observe that we call the district stakeholders to be a part, but then we don't reserve the time to do that. We appreciate all those that are able to ensure they are jointly planning with us, jointly implementing with us. And that's our continued ask. And as we do this, let's ensure we focus on feedback, so that every other time we aim at improving, but also let's push for integration. If you are aware that LPHSK has this activity, and then UHA is coming. Talk to us about integration. We as partners are also ensuring we do a regional and district level partner coordination, but sometimes a few things skip through, but at district level, we have an opportunity to catch this and advocate for integration. The other aspect is ownership. Everything we are doing on your behalf. Everything we are doing on behalf of the government of Uganda. Because if it's not that, then we wouldn't be here. So we ask that we own our interventions, we own our programs, because this is very key to sustainability. We don't want to hear that when PACT Karamoja left, the TP challenges worsened. PACT has been implementing with us for the last 5 years, and therefore we should be able to scale up and sustain those interventions as our district-owned interventions. The other is already alluded to by yesterday's discussion. Recruitment management. Okay, we have a challenge that our staffing levels in health are very, very, very low. Okay, that is already a big challenge. But we may have a bigger challenge that even with the low numbers we are actually not managing them properly. A lot of organized absenteeism. There's a lot of neglect duty, and we as key stakeholders, LC5, RDC, CAB, DHO, if we all speak the same voice, even the few can be able to give us. Sometimes as we partners come down, you go to a facility where you're expecting 15 staff, and you find 2 health workers, even when you want to do their capacity. It becomes a bit of a challenge. So let it be an interest of all of us. Ensure that the few staff we have actually are doing the best they can amidst all the other challenges. But also advocate, and I know Kotido yesterday, the chairperson, was able to express his frustration. But we need to continuously, I mean the CAUS, the LC5, RDCs, there are platforms where we can advocate. The Karamoja staffing levels are in an appalling state. So let's continue doing our advocacy. Chairperson, Kotido, please don't give up. We need to continue pushing so that we are able to improve that. The other is a very, very important center that was launched yesterday, the Karamoja Public Health Emergency Operations Center. This is a coordination center, but without information coming in from the portal to the regional coordination point, it's totally useless. So let's popularize LC5 as we move out. Please let the people know that this center, unfortunately, the toll-free line is not yet set up, but this center is here for any suspected case. And I know the secretary, the senior executive consultant will share a number of the contact person. But let us popularize this so that information comes in. Let us not have a repeat of what happened in the central where we had Ebola and it first killed a number of people before we actually got any suspicions. It doesn't matter whether it is a false alarm. It is better investigating. And how best to do that? It is if we make popular our the regional emergency operations center. Finally, and I was happy yesterday this was brought up. We have infrastructure development pledges. I know the commissioner spoke to that, but again, as key stakeholders, let's continue following this up. Every time we go into advocacy discussions, many times we hit a stone wall because there is this long-standing pledge. So as key stakeholders, LC5s, RDCs, let's be interested in tracking the progress of the Italian cooperation grant. It is very many of our challenges. We as partners are a bit constrained. Infrastructure investment is usually heavy and we cannot really tap into that. But if we follow up on this pledge, we believe that a lot is going to be changed. So thank you very much. These were our key asks. I mean, there were very many, but we really picked out the critical that we wanted to share. Next. I think I said yes. Thank you very much.
Thank you, Dr. Joseph. Yeah, this is an innovation where we're looking at all USAID partner under one umbrella. That shows you how coordination has matured to a certain level that all USAID umbrella partners in the region are able to come under one umbrella and speak a common setting. There is no more asking for fuel from UHA and then you go and ask for the same fuel from back Karamoja and ask for the same fuel to go and transport one patient. That is something I learned some time back. Yeah, I know we are between our lunch, but I also want to interest us. I know the SPCA team had your presentation came in later, but we also want to recognize social behavioral change activity under SID. And I know they've been supporting us a lot on community engagement, all especially around behavioral communication, the IEC materials, radio talk shows, the technical assistance in terms of development of community engagement strategies, and then how we can reach out to community. They've done a lot of studies, I think in Gabon and across, and we're trying to learn from them. How do we enter these Manyata crowds? There are quite a lot of studies, and I know in a number of other platforms we can have additional looks at that. But take note of the key asks. I also want to give some ground, a few minutes to our colleagues in the UNICEF block, the UN block as well. We have UNICEF, but then I think I have World Food in a short time. I know there are a number of asks that we may not repeat and give things. Just give us the spot on things that you expect these gallant members in the House to really appreciate. You're welcome, Richard Towondo.
Thank you very much, Dr. Brian. Thank you, colleagues, for this far we have gone. I want to first of all take this opportunity to thank all the partners and the government for this platform that we have put, planning together, our performances together. So just briefly proceed. IT, proceed. So UNICEF, when you see CST, that is Child Survival and Development, health belongs under the section that we call Child Survival and Development. It includes the aspect of nutrition, the aspects of water and sanitation, and everything. And we operate through the corporate agreement that we signed with the government of Uganda. The current PD is actually expiring next year. We signed every 5 years. Implementing is for 2021 to 2025, and we are in the process of developing a new country program, and most of your stakeholders shall be reaching out to you. Let's proceed. Those are just some of the outlines. So UNICEF's mandate, we actually support UNICEF's mandate. We realign it to the Sustainable Development Goals and also the national. And also the National Development Plan, of course, stemming from the Vision 2040. And when you look at our current rolling work plan under the section of Child Survival and Development, ensure by 2025, the new adolescent boys and girls, especially those in the most disadvantaged areas, are able to use quality integrated health, nutrition, and HIV services. The scope of operation within Uganda, we have a criteria we use and have the 29 priority districts. For Karamoja, all the 9 districts are categorized as vulnerable, and the support is both in health, education. Our model of implementation is through ministry, the local governments, as well as the partner support, meaning the districts support directly. So we don't do direct implementation. So at the different outcome areas that we have under CSD, the first one is the maternal and newborn health. Then the second one is the child health, looking at. Then the third one is under adolescent health with HIV as a cross-cutting. And we have the fourth outcome area under nutrition. And then, so I had just put a few of the activities we are supporting under different output areas, but I'll just be going through them very fast. We focus so much on the capacity building, especially on the area of MNH.
And also, sometimes we supply the equipment to our health facilities according to the need. I think this is based on maybe different facilities that have urgent need, but it's not like a routine planned activity. Then we also support that is needed, also supplement the support to the region through providing oversight, support, supervision during the capacity building activities. Under immunization, we are supporting, of course, community outreaches with the supporting of the vaccines and the cold chain maintenance. We also supporting the micro planning at the district level to ensure the zero dose and the under-immunized children are identified. We are also collaboratively working with the Malaria Consortium currently to identify and register all the children who are under-immunized and the zero dose, integrating it under SMC. Let's proceed. Then the other activities we are supporting is actually around the supporting DFT members to conduct support surveillance. We realize that sometimes the support the partners provide and government is actually matched. And the supervision, especially, for example, outreaches in the communities, one of the reasons why some outreaches are not done is because maybe the supervision is lacking within the health facility. So the DHOs or the DHT members are supported to go and conduct some supervisions. We also supported the MOH to establish those are the ones we call daycare. I hope they are still functional. Then we also supported by distributing around 53 laptops to different health facilities. I think the regional Pheoc and the Moroto district were the biggest beneficiaries. The regional Pheoc got around 10 laptops, and then the Moroto district. Let's proceed. Under nutrition, we mainly support the nutrition mass screening across all the districts. We also support nutrition health integrated community outreaches. We are supporting human resources within the region. We have 5 nutritions seconded within different districts that don't have nutritions, Nabilatu, Nakapelfuri, Kabongo, Kotiga, and Oroto. And of this year, maybe government should be planning to take on some of those nutritionists. We also support the OTC and ITC management, and then the RATF supplies. Of course, right now we are doing that through enemies. Under WASH, we support the rural water supply, and right now we are focusing so much on the mild water use systems. And yes, this year we don't have, but starting next year we shall be establishing more. For this year we are doing more operation and maintenance. And we are also looking at areas where we can establish water sources where the facility, the schools, and the community benefit. Let's proceed just in summary. These are some of the resources. And for example, from January to December, UNICEF has disbursed roughly around 3.5 billion. This is an exception of the indirect support that comes, for example, from the ministry. They are doing the mass vaccinations, the yellow fever, and all other campaigns. This is a direct support that has gone to districts under different output areas. You can see maybe the biggest, the allocation is based on the need at that point, according to how we analyze the indicators. Maybe Kabong is actually, Kotido is receiving the biggest chunk, but it's also based on the population that the district has. So if we can proceed. Then for the remaining part of the year, so far the funds that have been confirmed or earmarked for disbursement starting September, it's actually around 589 million under different output areas. These resources are mainly used according to the work plans that we agreed together between UNICEF and the district to supplement the government mandate. Let's proceed. So among the challenges or where the key asks are, is not very different from what the colleagues put forward. If I may just speak through the first one, the challenges around the access to finances within the government systems. That is leading to delayed accountabilities. I will just give an example in the recent response for measles. I know sometimes there are times when the activities need to be implemented very fast. There's an emergency. I know we conducted a lot of activities, including mass vaccination. The funds were sent to the districts, but I'm very sure up to now, the health workers who supported the implementation have not yet received the funds, which kind of puts the partner into spotlight as if we are not giving the funds on time. Maybe we need to engage the Ministry of Finance on a review and do something around the payment systems, as we also internally explore other alternative payment modalities during the time we implement the district. And then the issue of partner coordination, I think it came out very clearly from Dr. Joseph's presentation. I think we need to purpose to collaborate and coordinate very well. I know there are times when we really want to fight for space, and if I may put it, like for example, some partners may think when you collaborate, then your efforts may be overshadowed. I don't want to look at it that way. Yes, I know that sometimes we've done it well like this time around, but I think we can still do better. Thank you very much. If I may just summarize in the interest of time. Thank you.
Thank you, Richard. I think these lessons have been good. To learn from us how G2G is working, because I think they work for us very nicely, and we do payments in time. World Food Program is in the end also. Okay. Ladies and gentlemen, we have Malaria Consortium. Is your presentation? Okay, I want to release us for break and then for a lunch, and then we will be looking at one item or so. I want to interest us in the house that the Tally Center is about to be done. The district is the best, we perform the best in health financing. And we want to interest ourselves in how are we financing health in the, so make sure you keep around so that you receive your reward. Otherwise, if you don't receive your reward, we'll give it to another one. We'll see which stakeholders want to escape for receiving the award. So the award is right there and is waiting for the best performing district. In a minute or so, Dr. Dong, do you have a comment? Dr. Dong, as we thank God for Malaria Consortium and the LC. Hopefully you received your money.
Good afternoon, everyone. My name is Dr. Onongo Musa, but usually I'm sort of, if you just stop at Musa. I'm going to give you a short, I have just 5 minutes to do a short presentation on So Malaria Consortium is a that supports disease control globally. In Africa, we are spread across West Africa and Southern Africa. And particularly in Karamoja region, we have other programs within the country, but for Karamoja region, I'm going to speak briefly about seasonal malaria chemo prevention, which is a Ministry of Health program. It's not a Malaria Consortium program. I would like to make that clear. It's a Ministry of Health and district program. Malaria Consortium only comes in to support implementation. And the brief story about SMC Karamoja is that around 2018, when the ministry did the malaria indicator survey, we wasn't a surprise finding, but of malaria. And so because of the constant high prevalence in the region, when the ministry decided to tailor interventions by region, there was a realization that SMC could be one very appropriate intervention for Karamoja, and especially children below 5 years. So we implement SMC, targeting children 3 months to 59 months, and we use medicine called sulfadoxine pyrimethamine plus amodiaquine combination treatment. We've done this for the past about 3-4 years since 2021, and implementation is actively done from the months of May to September. The scientific rationale is that from May to September is when there is peak transmission season. Although there's a bit of argument about that, but data shows us that about 60-70% of cases fall within that month of May to September. And so we've done year 1, year 2, and year 3. And our targets, we're now in year 4, our targets have constantly increased because in year 1 we had in the 2 districts, and SMC was introduced within the country as a research kind of implementation science. We had a lot that we needed to learn from implementation, so we did a lot of studies to try and understand how implementation works. In this presentation, next, I'm going to show you, we'll just talk about 3 studies that we did to demonstrate how SMC works in the Karamoja region. The first we did was an acceptability study to try and understand if the population within the region accepts the intervention, if the leaders do accept it, and I can clearly testify that all the leaders that are in this room have had a feel of how SMC works. And we haven't had any leader saying this intervention should be thrown out of Karamoja. That's the big finding from that study. The second study we did was to understand, in Uganda we have a very high prevalence of certain markers of resistance to the chemicals that we use, sulfadoxine, pyrimethamine, and amodiaquine. So we needed to understand if we use the same medicines in an area where there is high prevalence of certain markers of resistance, which may mean the medicine will not work. We wanted to understand if we implement using the same medicines within this region, will it have an effect on, and the biggest indicator we are looking at is incidence of malaria among children who are targeted. And this study has already been published. You can go to the next slide. It has been published, and we found out that SMC pyrimethamine plus amodiaquine, which we commonly call, uses malaria incidence compared to those who don't receive. We did this study in Moroto and Kochido with Nabilato as a comparison district. And the children who are enrolled in the study were able to demonstrate those who never received SMC at all. Now, because of the high prevalence of molecular markers of resistance in Uganda, we, together with the funding agency, we thought through about looking for another medicine, just in case SMC using SPARC is not feasible because of high prevalence of resistance. Should we think of another medicine that we can use? So we did another study in Amdat district. This was, next slide, this was a cluster randomized trial. No, it's okay. We did a cluster randomized trial in Amdat district, comparing another medicine called dihydrotemisinin preparatory, commonly called DP. We had children who were enrolled to take DP, another group was enrolled to take SPARC, and then we also had a comparison group which never received anything. And we wanted to compare malaria incidence in the different groups. All right, and incidentally, we found out that the two medicines, SPARC and DP, all contribute to a significant reduction in malaria incidence among children that received it for SMC. All right, we initially thought one of the medicines would provide a better protection. That both SPARC and DP offered more or less protection to children when they receive it for SMC. So Spark, SMC using Spark wasn't inferior to SMC using DP. The only significant issue about SMC using DP is that the cost of procurement of DP is quite expensive. It's about 5 to 10 times higher. So the preference for now is to implement SMC using DP. We are planning this study, the manuscript has already been submitted for publication. We're also planning a nationwide dissemination, then a regional dissemination for the different studies that we have done related to SMC. These are just 3 studies. There are about 10 others, sub-studies that we have done to try and demonstrate to the donor community that SMC using DP and SPAQ works in Uganda. We've also had challenges implementing SMC because the premise is that when you treat every child during the pig transmission season, then you should see at the health facility very few cases of children with malaria. But we still have children with malaria in the facilities. And some of these are children above 5 years old. And so the discussion right now is transitioning from how can we implement SMC even for older children, because the WHO already come up with a policy and guidance on how countries that want to implement SMC in older children can go about doing it. So thank you very much.
Thank you, Dr. Musa. Ladies and gentlemen, according to our data, we see that malaria is our biggest problem in Karamoja, and that's why we need to always interest ourselves in some of those studies. The issue is the problem is still here with us, that is a study. So what do we do to avert the biggest problem? Many children are still dying of malaria in Karamoja. At the same time, the question we'll be asking ourselves, what do you need the cultural leader to do when it comes to malaria intervention? What should the SFI do? What should the RDC do? And what should the DHO do? And some of those are questions we need to ask ourselves after these studies. We know the other chemoprophylaxis candidate is scaled up. Some of those are key questions that I think the House will have to ask you. Members, I think we are between our lunch, and I want to release us for a lunch break. At least 40 minutes. We want to come back and wind up so fast, and I know what is left of us is very short, and we want to have an afternoon which is quite fast for us. So that we're able to wind and release you quite earlier than yesterday. I know we have a lot of other engagements, and I think we will be within our time range, given the fact that we've had already some partner presentations and at least one abstract to address issues of malaria come out for us to learn from. I think the rest of questions will come in the after lunch. Most of us are hypoglycemic. It's already through, yes, 27. So I think we regress our lunch. We will regress our lunch too. Members, make sure you eat food fast, like some military, some guides the bits that we are able to beat. And the faster you finish lunch and you come back, the faster we'll finish. Yesterday, we lost some time during lunchtime, and today we do not want to lose time. Let us grace. Let us pray for lunch. The Lord, we thank you for the gift of provision and the gift of lunch with us. And we thank you that you continue nourishing us with fresh ideas as you refresh us during lunch break. And we're looking forward to a blessed lunch, safe in our stomach and also safe for our nourishment. And thank you for the gift of provision. And those that are funded, continue blessing them. In Jesus' name we pray. Amen. God bless you. Blessed lunch. Hello.
Yeah. Yes, my dear. Yes.
I presented probably.
No. It's a food.
Help you with this one, the other one.
Yeah.
Sign up.